Cancer care reflects all the strengths and weaknesses of health systems. It's almost certainly one of the most fragile of disease areas to look after in a conflict. And over the last few years, we've seen two extraordinary bloody conflicts, one very recently between the Hamas and the IDF, and obviously between Russia and Ukraine, which has now actually been going on for almost 7 years, although the recent conflicts expanded nearly 16 months ago. These are two very, very different ecosystems. The impact on cancer care in these two countries is very different. Firstly, with Ukraine. Ukraine had already undergone quite a lot of development of its cancer services. The individual oblasts within Ukraine were already quite stabilized, although there were issues with delivering some of the more modern aspects of radiotherapy and modern chemotherapy. Certainly when it came to surgical oncology, diagnostics, Ukraine had evolved quite a long way before the current conflict. And so when the conflict initially started in Ukraine, we were working from a very different base. Ukraine was also surrounded by many countries with a great deal of depth in terms of their capacity and capability to absorb refugees, to provide help inwardly, and also to provide, particularly, for example, in childhood cancers, evacuation, and that was managed by the St. Jude's Hospital in Memphis. And so the ecosystem for stabilizing cancer and cancer patients with the Ukrainian war has been very different. Obviously, over the last few months in Ukraine, there's been huge numbers of attacks against infrastructure, particularly electrical infrastructure, and that's also taken a major toll. But even now, we've managed to adapt to those situations by providing generators, a lot more backup power situations. And so Ukraine is at a much more stable level. The challenge for Ukraine really is going to be in the future in terms of rebuilding the health system once the war ends. What we're seeing in Palestine and Gaza is very, very different. Really, after 17 years, essentially, of being sealed off under what is essentially a siege that's been occurring with Gaza, that the infrastructure was already very, very weak. Although some cancer surgeries were able to be carried out, that there was chemotherapy could be delivered as well at a low level, all radiotherapy had to be referred outside Gaza to the Augusta Victoria Hospital, which meant for many patients that radiotherapy into Gaza. But of course, Gaza was coming from a much weaker perspective. Over the last 16 days, what we've seen, of course, is the devastation of most of northern Gaza, and that's essentially meant that all cancer care across all the hospitals has simply ceased. All the surgical care has been moved, obviously, onto trauma. The medicine stockouts are nearly all depleted. There are a few medicines left, but they are being used just for the childhood cancer patients. There's obviously no radiotherapy. And of course, nearly all patients, no one's really turning up at hospitals. So the critical problem there really is one of needing a ceasefire and a humanitarian corridor, and they're at a very, very different state from Ukraine. Ukraine's going to be, I think, a complex picture. There's no doubt we're going to see stage migration. In other words, patients are going to present later. And the reason for that is simply, of course, that it is more difficult to access care even in Ukraine. A lot of the adult population is now engaged in the war economy. They're front line, they're providing logistics support, so they're much more likely to ignore their symptoms and present late. So Ukraine almost certainly in the future is going to see a lot more advanced cancer cases, and that's going to be, I think, a challenge for a system as it tries to get back on its feet. And bearing in mind, it's much, much more expensive to treat advanced cancer patients than it is early cancer patients. Having said that, though, there's a lot of planning going on at the Ministry of Health level and at the individual oblast level to put together pathways and plans for now and for the future. So I think the situation in Ukraine is stable, and I think one can be hopeful that with the right sort of inward investment from the multilateral development banks, by the right sort of support from Europe, that we will actually see a very strong system in Ukraine emerging. Gaza is a very different matter. Right now, there is no health system to speak of whatsoever. The future is simply unknown. We're in the midst of a major war here. It is simply basic 101 humanitarian needs. And unfortunately, within this situation now, cancer is not going to take priority in any shape or form. for the major reason that, of course, we're having to deal with stockouts in basic surgical equipment. Wounds are having to be disinfected with basic cooking vinegar. So we're talking about what I call basic humanitarian needs. The future of Gaza in terms of cancer control, I think, is very uncertain. Up until now, there's been a lot of work by the World Health Organization on cancer planning, both in the West Bank and Gaza. I think all of that right now is up in the air, and the future is deeply dark and uncertain. It's been very complex trying to study the epidemiology of cancer in conflicts. The data systems are degraded, it's very hard to get accurate diagnosis, it's very hard to follow up patients, because even if a diagnosis is made of a patient in a conflict area or a refugee, they often then disappear from the system. What we do know, of course, is war is carcinogenic. And I use that as a broad example to show that when conflicts occur, you have a number of things happening. First of all, greater risk factor take up. More people smoke, there is more alcohol abuse, diets are very poor, we get more sexually related cancer starting, etc. So all the pro-cancer risk factors that we see in permissive, non-conflict environments rapidly escalate during a conflict. And unfortunately, they tend to stick in refugee populations. So we see tobacco control being a really, for example, major issue. We also lose all the advantages in a stable environment of screening. So when we're talking about elimination of cancer of the cervix, of course, there's almost no screening that goes on in refugee camps or of displaced populations. And the idea that these populations then have an early diagnosis. So that's a major issue. And then there's this conflicting problem around explosive weapons and the fact that a lot of modern weapons now create enormous environmental destruction. They toxify the environment, so these are heavy metals, these are complex polyaromatic carbons that come out of the propellants, and they also destroy the agroeconomy, so the agricultural areas and the urban areas, and that releases even more toxins into the environment. So there's no doubt the environment becomes incredibly toxic. And that as a whole almost certainly will lead, in some cases, to cancers further on down the stream. But the relationship is very complex from an epidemiological perspective. But what we do know is this toxification of the environment also leads to massive increases in antimicrobial resistance. So you can imagine downstream, even if it has no effect directly on increasing the incidence of cancer, what it will have is make life much more difficult for treating our patients. Immunosuppression of cancer patients of our treatments, when you've got such rampant antimicrobial resistance, is a huge problem. But the prevalence in the epidemiological studies, the incidence and prevalence studies and general epidemiology is fraught with errors in the literature. But broadly speaking, conflict we know is very bad.